Welcome back to the deep dive. Today we're getting into really the numbers game of the human body, the cardiovascular system. We often think about the heart metaphorically, but physically. It's basically a hydraulic system. It runs purely on physics and pressure. If those pressures aren't right, blood doesn't go where it needs to, and, well, things can fail, sometimes quite dramatically.
That's a perfect way to put it. Yeah, it's all physics. And you've gathered some great sources here on hemodynamics, fluid balance. Our mission today is to take these numbers, these pressures that can look pretty intimidating on a monitor or a chart, and translate them. We need to see how they act as signals. It's not just knowing the normal range, it's understanding how, say, a few millimeters of mercury difference can point straight to a leaky valve or even, dangerous fluid in the lungs.
Okay, so let's unpack this. Where do we start?
Yeah.
The most basic rule, right? How blood flows. It needs a gradient, like water flowing downhill.
Exactly. The absolute foundation here is flow only happens from high pressure to low pressure, always. The heart chambers, all four of them, are basically specialized pumps just designed to create and maintain these pressure drops, one after the other, to keep blood moving forward.
And we see that basic physics literally every time a heart valve opens or closes.
Precisely. Think about the mitral valve between the left atrium and ventricle. When the heart's relaxing and filling that's diastole, the pressure in the left atrium has to nudge just above the pressure in the ventricle to pop that valve open. Then boom, systole happens, the ventricle squeezes. Now its pressure has to skyrocket way past the pressure in the aorta to force that valve open and push blood out to the body. It's this constant pressure competition.
And when you look at the baseline pressures, the difference between the left side of the heart and the right side is huge. It's like comparing a fire hose to a garden sprinkler.
That's a great analogy, actually. The systemic circuit, the left side, that's the high pressure system. The left ventricle is the powerhouse. It has to generate really high pressures, typically, 100 to 140 millimeters of mercury systolic. Needs all that force to push blood through the entire body's resistance.
Whereas the right ventricle has a much easier job, physically speaking. It only pushes blood next door to the lungs.
Right. Lower resistance circuit. So the right ventricle, it only needs to hit maybe 15 to 30 millimole in Hg during systole, much lower. And if you start seeing those right-sided pressures climbing up towards left-sided levels, that's a huge red flag. Tells you something's wrong in the pulmonary circulation, maybe pulmonary hypertension building up. And speaking of the right side, the pressure in the right atrium itself, normally very low, like 2 to 8 millimole Hg. That's incredibly useful clinically.
Ah, right, because that's the one we can estimate just by looking at the patient without invasive lines.
Absolutely. That right atrial pressure, which is basically the filling pressure for the right side of the heart, it directly reflects in the jugular venous pressure, the JVP. You see a high JVP in the neck, you know that RA pressure is up. Could be fluid overload, could be the right ventricle struggling to take blood in. It's a window into the right heart.
Okay, but to really get a handle on the left side status, especially in critical care, we often need more direct info. This brings us to that famous tool, the pulmonary artery catheter, or Swan-Ganz. And the key measurement it gives us, the pulmonary capillary wedge pressure, the PCWP. Sounds complex.
It's actually a brilliant piece of engineering. You insert this thin, flexible catheter into a large vein, like in the neck or groin, and then you carefully float it along with the blood flow. It goes through the right atrium, then the right ventricle, and finally lodges itself in the pulmonary artery.
Okay, so it's sitting in the pulmonary artery.
Yeah.
But the measurement we want is the wedge pressure. How do we get that? There's a balloon involved, right?
There is. Once the catheter tip is snug in a smaller branch of the pulmonary artery, there's a tiny balloon near the tip that you inflate just for a moment. That inflation wedges the catheter, basically blocking the blood flow coming from behind it in that small artery segment.
Okay, blocking the flow. Why is that the clever part?
Because stopping the flow creates a situation where there's a continuous static column of blood. It stretches from the catheter tip back through the pulmonary capillaries, through the pulmonary veins, all the way to the left atrium. Since there's no flow, the pressure equalizes along that whole column. So the pressure measured at the catheter tip now reflects the pressure back in the left atrium. It's an indirect look at the left heart's filling pressure.
Ah, got it. So that gives us that crucial relationship, the sort of golden equation for the left heart. PCWP approximately equals left atrial pressure, LAP, which in turn usually equals the left ventricular end diastolic pressure, LVEDP, the pressure right before the ventricle squeezes. So the wedge pressure is basically our best non-direct way to gauge the left ventricle's preload, how full it is.
That's the fundamental assumption, and yeah, it's incredibly powerful in practice. A normal PCWP is pretty low, maybe 6 to 12 million mHg. If you get a reading back, say 25 mmHg, alarm bells. It's just the left ventricle is overloaded or failing, and that pressure is backing up towards the lungs.
But you said usually equals. Is there a catch? When does that neat little equation break down? What condition messes up that PCWP equals LVEDP relationship?
Ah, yes, the critical exception everyone needs to remember, mitral stenosis. Stenosis means narrowing, stiffness. So with mitral stenosis, you have a physical blockage, a traffic jam, between the left atrium and the left ventricle because the valve won't open properly.
So the atrium is working overtime, pushing against that stiff valve.
Exactly. The left atrium pressure has to climb really high to try and force blood through that narrowed opening. So the PCWP, reflecting that high LA pressure, will be very elevated, maybe 25 mmHg, like in our example. But crucially, because the valve restricts flow into the ventricle, the left ventricle itself might actually be underfilled. Its end diastolic pressure, the LVEDP, could be normal or even low, say 12 mmHg. So now you have PCWP, high, way greater than LVEDP, low normal. That large gradient is the diagnostic fingerprint of mitral stenosis. The approximation failed, and that failure tells you exactly what's wrong.
Okay, so these pressure differences, these gradients, they're like instant diagnostic clues. Let's use that idea. How about other valve problems? Aortic stenosis.
Aortic stenosis, yeah, that's the classic example of a massive systolic gradient. Normally, when the left ventricle squeezes, its pressure and the aortic pressure are almost identical during ejection. But if that aortic valve is tight, stenotic, the left ventricle has to generate tremendous pressure. Let's say it hits 180 mmHg just to force blood through that narrow opening and maybe only achieve a pressure of 100 mmHg out in the aorta. That huge 80 mmHg difference. That screams aortic stenosis.
Okay, we've covered stiff valves.
Yeah.
What about when the pump itself just gets weak or stiff? Like in left ventricular failure. How do the pressures reflect that?
Right, pump failure. If the ventricle isn't ejecting well or it's become stiff and can't relax properly to fill, the pressure inside it at the end of filling, the LVEDP, goes way up. Maybe it hits 25 mmHg. And because there's no valve blocking the way back to the atrium during filling, that high pressure immediately transmits backward. So the left atrial pressure rises, and therefore the PCWP rises right along with it, maybe also to 25 mmHg. That high PCWP is the direct cause of fluid backing up into the lungs, leading to congestion and pulmonary edema.
And then there's cardiac tamponade. That's different, right? The muscle might be fine, but something squeezing the heart from the outside.
Exactly. Tamponade is usually caused by fluid building up rapidly in the pericardial sac around the heart. It's like the heart is trapped in a tightening bag. The key finding with the pressures here is really striking. You see equalization of the diastolic pressures across all chambers. The right atrial pressure, the right ventricular end diastolic pressure, and the PCWP, reflecting left atrial, left ventricular diastolic pressure, they all become nearly identical and elevated. Say they all land around 15 mmHg. This equalization tells you there's an external force limiting how much any chamber can fill.
Wow. Okay, so this kind of data from the PA catheter must be crucial for figuring out why someone's in shock. If a patient's crashing, how do these pressures tell us if it's, say, pump failure versus just not enough blood volume?
That's a classic use. It really comes down to the filling pressures, especially the PCWP. In cardiogenic shock, the pump itself has failed. The heart can't move blood forward effectively, so pressure backs up behind it. You'll see a high PCWP. At the same time, because the pump is weak, the cardiac output, CO, the amount of blood pumped per minute, is low, and the body tries to compensate by clamping down blood vessels everywhere, so the systemic vascular resistance, SVR, goes up. High PCWP, low CO, high SVR, that's cardiogenic shock.
Okay, and contrast that with hypovolemic shock, like someone bleeding internally or severely dehydrated.
Right. In hypovolemic shock, the problem is simply not enough volume in the pipes. The tank is empty, so the left ventricle isn't getting much blood back to fill it. Therefore, the filling pressure, the PCWP, will be very low. It plummets. The cardiac output will also be low, naturally, because there's nothing to pump. But, like in cardiogenic shock, the body still panics and clamps down vessels, trying to maintain pressure, so the SVR will also be high. Low PCWP, low CO, high SVR points strongly to hypovolemia. The PCWP is the key differentiator there.
Okay, we've charted the course through the big chambers and pipes. But the real action, the exchange of fluid and nutrients, happens down at the microscopic level in the capillaries.
Yeah.
So now we need to shift gears, right? pivot from the big heart pressures to these Starling forces that govern fluid balance in the tiny vessels.
Exactly. We're zooming way in. At the capillary level, it's not just about bulk flow, it's about fluid movement across the capillary wall. And this movement is controlled by a balance of 4 specific pressures, the Starling forces. They determine whether fluid gets pushed out of the capillary, that's filtration, or pulled back in, reabsorption. It's like a constant tug of war across the capillary wall.
Okay, let's break down the 4 players in this tug of war. What's the main pushing out force?
That's the capillary hydrostatic pressure, usually written as PC-DOR. It's simply the blood pressure inside the capillary itself, physically pushing fluid outwards into the surrounding tissue space, the interstitium. This pressure is very sensitive to venous pressure. If pressure backs up in the veins, PC-DOR goes up, and you get more filtration. Opposing that push slightly is the interstitial hydrostatic pressure, which is the pressure of the fluid already in the tissue space. Normally it's very low, sometimes slightly negative, and it sort of resists fluid coming out.
Okay, so those are the physical pressures. Then we have the pulling forces, the oncotic pressures, and proteins are the key here, right?
Absolutely. The major pulling force drawing fluid back into the capillary is the plasma oncotic pressure. This is generated by proteins, mainly albumin, that are dissolved in the blood plasma but are too large to easily cross the capillary wall. They act like little sponges, exerting an osmotic pull that holds water inside the vessel. This is the main force driving reabsorption. And then the last force, usually smaller, is the interstitial oncotic pressure. This is the osmotic pull generated by any small amount of protein that does leak out into the tissue space. It tends to pull fluid out of the capillary.
So you've got these 4 forces constantly battling. When does this balance tip over into edema, into visible swelling? What's the basic rule?
Edema happens when the forces pushing fluid out, that's high PCR, high PI, overwhelm the main force pulling fluid in, which is the bucket, or, put another way, filtration exceeds reabsorption. And critically, this imbalance has to also overwhelm the lymphatic system's ability to drain away that excess fluid and leaked protein from the tissue space. When the lymphatics can't keep up, you get edema.
Right. Let's connect those forces to real clinical pictures. Congestive heart failure, CHF, probably the most common cause of swollen legs and shortness of breath, which Starling force is primarily responsible there.
CHF is the classic example of elevated capillary hydrostatic pressure. The failing heart leads to backup of pressure in the veins. That increased venous pressure directly transmits to the capillaries, especially in dependent areas like the legs. This high PSI physically pushes excess fluid out into the tissues, causing that pitting edema you see.
And it's the same mechanism causing fluid in the lungs, pulmonary edema, and left-sided heart failure.
Exactly the same principle, just different location.
Yeah.
When the left ventricle fails, we saw the PCWP goes up. That high pressure reflects high pressure in the pulmonary veins and capillaries. So pulmonary capillary PC-DOR rises. The general thinking is once that pulmonary PC-DOR gets above about 20 millimilli Hg, the pushing force is so strong that fluid floods out of the capillaries into the air sacs, the alveoli. That's cardiogenic pulmonary edema. It's hydrostatic pressure driven. It's a transudate, mostly water.
Okay, now let's flip to the pulling forces. What if you have a patient, maybe a child with puffy eyes and protein in their urinonephrotic syndrome, or someone with advanced liver cirrhosis? They often have generalized swelling. What's gone wrong with the Starling forces there?
In both those conditions, nephrotic syndrome where the kidneys leak protein and cirrhosis where the liver can't make enough protein, the core problem is a loss of albumin from the blood. This causes a significant drop in the plasma oncotic pressure. Remember, that's the main force pulling fluid into the capillaries. If that inward pull is weak, even normal hydrostatic pressure can push fluid out relatively easily. And since the protein loss affects the whole body, you get generalized edema.
What about something different like sepsis or ARDS, acute respiratory distress syndrome? Patients can get very swollen or their lungs fill with fluid, but sometimes their heart pressures, like the PCWVP, are actually normal. What's happening there?
That's a permeability problem, not primarily a pressure problem. In severe inflammation like sepsis or ARDS, the inflammatory mediators damage the endothelial cells lining the capillaries. The capillary walls become abnormally leaky. Think of it like the barrier developing holes. This increases what we call capillary permeability. Now, not just fluid, but large molecules like protein can easily escape into the tissue space. This creates an exudative edema, rich in protein, even if the hydrostatic pressure isn't particularly high. The leakiness itself is the main driver. Maybe the PCWP is only 12 millimilli Hg, but the lungs are still wet because the capillaries are compromised.
And one more type, lymphedema. Say, a patient who had lymph nodes removed for cancer surgery now has chronic swelling in that arm. How do the Starling forces explain that?
Lymphedema is purely a failure of the drainage system. The lymphatic vessels normally collect the small amount of fluid and protein that inevitably leaks into the interstitium and return it to the circulation. If those lymphatic channels are blocked or were removed, that protein and fluid gets trapped in the tissue space. The trapped protein builds up, increasing the interstitial oncotic pressure. Now you have a stronger osmotic pullout in the tissues, which continually draws more water out of the capillaries, leading to that persistent, often hard, non-pitting swelling characteristic of lymphedema. Hashtag tag outro.
Wow, okay. That really covers the spectrum. We went from the huge pressures inside the heart chambers right down to the tiny, delicate balance of forces in the capillaries that decide where fluid goes. It seems the big takeaway is that these numbers, these pressures, they aren't just abstract values. They directly tell a story about what's breaking down in the system.
Absolutely. And that core relationship we discussed, PCWP approximating LAP and LVEDP, it's such a useful starting point for thinking about the left heart. But as we saw with mitral stenosis, you always have to think critically. Does the approximation hold? If not, why not? That discrepancy itself is often the diagnosis.
Okay, let's leave our listeners with a final thought, something to really integrate all this. Imagine you encounter a patient diagnosed with severe pulmonary artery hypertension. Their mean PA pressure is measured at, say, 45 mmHg, really high. Based on our discussion of pressure backup, your first thought might be, okay, the pressure must be backing up from a failing left heart, so the PCWP should also be sky high.
Right, that would be the assumption if the problem started on the left side. But what if you perform the Swan-Ganz measurement, you get the wedge pressure, and it comes back completely normal, let's say 10 mmHg. What does that finding a severely high PA pressure but a perfectly normal PCWP tell you definitively about where the obstruction, the high resistance, actually is? And why is figuring that out so absolutely critical for diagnosing the type of pulmonary hypertension and guiding treatment? That disconnect between PA pressure and PCWP is key, something to definitely mull over.